يعطيكم العافية جميعا. أول إشي بحب أشكر إدارة المؤتمر لإعطائنا فرصة لتقديم الفاسكولار سيشن في هاي السنة، وإحنا دائما بنحب نقدم كل سنة وإنه good history مع our colleagues in the cardiology department. This session will be vascular session. It will be a short session about a couple of things. The first of the session will be presenting Dr. Mamoun al-Qaryouti. He's a vascular endovascular surgeon and a kidney transplant surgeon. He trained in multiple countries, including Australia, UK, and New Zealand. He will present today about a very interesting subject, and I think everybody is interested about hearing it, about vascular access complications. And the more we do endovascular procedures, we will encounter some vascular access procedures.
At the end of a long day, I'm from the generation who knows Claudia Schiffer, so I have to be Claudia Schiffer naked to be standing here to attract your attention. But I'll try my best, to be honest. So this is a sort of one of these amazing, simple but yet difficult topics, because every cardiologist, and this is directed towards the cardiologist, would deal with these issues, and they can be, as simple as a tiny ecchymosis to the degree of being a life-threatening problem. The axes that you use for interventions, for coronary interventions, are many, including the femoral, the radial, the ulnar, brachial, axillary, etc. However, the famous two are the femoral and the radial, and these are the ones we're going to be concentrating on. You can divide these into a classification depending on the intervention you do, or the complication you have, or the axis you use. We're going to go through it, these two major criteria, through a run through the complications that we might have with each of these axes. It's meant to highlight the complications and hopefully highlight ways to avoid them and ways to deal with them, rather than compare between the different ways to get access into these vessels. So if, a quick look at this sort of comprehensive slide of the femoral axis, the radial axis, and the ulnar axis to a lesser degree would tell us, the different percentages of possible complications for these, axis problems. However, let's take it one by one. So we go first with the femoral axis complications. And these are the commoner ones that we deal with every day. And vascular surgeons tend to be consulted about these every now and then, because it's an issue that needs to be dealt with and might be outside the realm of expertise of the cardiologist. The first one, and probably the simplest one, is a groin hematoma. This can be a very simple hematoma, which sort of, just needs a bit more compression, some ecchymosis, or into active bleeding that has bled externally and internally. Bleeding is a significant complication. And I warn you all, sort of a word of caution, to not underestimate the degree of bleeding some of these heavily anticoagulated cardiology patients might have. It's a life-threatening problem when you bleed and bleed and bleed, and the bleeding can be obvious externally or concealed. For each of these, we're going to look at the axis complication, the clinical finding that you might have, the diagnosis, and the possible secondary complications. It's self-evident with the groin hematoma that you might have pain, swelling, bruising. It's usually diagnosed by ultrasound or CT, and it can cause anemia or a neuropathy because of nerve compression. A major degree of bleeding would be the retroperitoneal hemorrhage, and this is a life-threatening complication. In fact, it has a mortality of about 6.6%, so it's quite significant, and it's important to recognize it early and to know how to deal with it. Retroperitoneal hemorrhage, for the ones who've been unlucky to deal with it, can be quite tricky, because your patient usually does not show any signs of external bleeding, and they usually sort of have this complication unrevealed during the evening period, hours after they had the intervention. At night, if you get a call about a patient who's sort of either blood tests show anemia, or feeling dizzy, or his blood pressure is gradually dropping, always think of a retroperitoneal hematoma. It's a concealed form of hemorrhage that needs adequate and immediate attention. And attention for this hematoma might include surgical repair. And I have the misfortune of dealing with some of these on an emergency basis, where you have a collapsing patient who had a posterior high puncture, sort of external iliac artery puncture, and they've gone to the degree of near arrest because of the hemorrhage into their retroperitoneum. The retroperitoneal space is massive and can take a few units of blood before it gets recognized. So it's a significant complication that we should be paying attention to, with a relatively high mortality. Another form of bleeding is a pseudoaneurysm, where there's a bleeding into the wall of the artery, the adventitia folds a sac around it, and it becomes a false aneurysm. This is sort of easily diagnosed because of the symptoms: pain, swelling, and a versatile mass. Duplex is very accurate, and false aneurysms post-coronary cath in the femoral region, a whole topic that has a multitude of ways to deal with it, and it's not within the scope of this talk, but the advances in this have made a great difference. And definitely thrombin injections, which are direct injections into the false aneurysm, have made a difference in the management, especially when it's indicated. Most of these false aneurysms are small, with a small neck. If you leave them for 6 weeks, they usually resolve on their own, but the ones which need treatment, we have a multitude of ways, including thrombin injections, surgery, or the previously mentioned, not much used now, compression therapy. Sorry, just missed one. Common femoral artery occlusion is another significant complication, and this one is also limb and life-threatening. And if it's not recognized, it's a problem. It usually is recognized because of the symptoms it causes. It causes the usual symptoms of ischemia, be it acute or subacute. And once you suspect there's a problem there is no pulse in the common femoral, distal pulses have disappeared, and you assess it, therapy has to be instituted, which can be either interventional or surgical. Frequently, it's an occlusion at the site of the puncture or site because of a flap or a thrombus, and it's easily resolved with a minor procedure. And sometimes, like the case with this one, this is secondary to occlusion device. You need to do some intervention in order to resolve it. Intimal injury is an interesting complication. This is one of our cases, and the presentation was sort of way after the procedure, about 2 months after the procedure, because of pain in the lower limb that the patient had, and sort of unexplained. She did have typical claudication symptoms, typical chronic ischemia pain symptoms. Angiography showed this amazing picture of an intimal flap that's sort of gone triangular in shape, with a small channel flow in between the two parts of the flap. With some of the views, I could manage to get a microcatheter and a 14 wire through that to balloon it and then stent it, and the end result was a complete resolution of symptoms. Intimal flaps are a significant complication, and they can be quite prolonged when you get a dissection of the external iliac or the common iliac, and that's something that needs attention to as well. Infection is a horrible infection that usually happens late. It's a puncture site infection. Treatment can be difficult, and some of these patients, you struggle with them for a long time, because after you evacuate the hematoma and the infection, they need vac therapies, wound care, all the forms of treatment for these significant infections. They do cause sometimes sepsis and septic shock, and they do have a mortality. So it's important when you recognize them that you're aggressive with the treatment, especially with the cultures, be it the blood cultures and the localized infection culture. Which brings us to the second axis, with all its problems, which is the transradial, and these have a multitude of problems, from the occlusions to the ones we're going through now. So radial artery spasm is the most common, and that's the one that most cardiologists will struggle with. It's usually have a few risk factors that can be a warning sign that might happen, including young age, female, a low body mass index, a small radial artery, or using a large size sheath, and you can prevent these by anticipating them, not using the large teeth, using the treatment early on, including verapamil or nitroglycerine infusions, and they usually resolve spontaneously. After that therapy, very few of them will progress to become an occlusion, and that's a problem, but extremely small number. Hematomas are quite common. They usually sort of compression or changing the site of compression resolves this, because frequently what happens when you compress the wrist with a wristband, you get the erroneous compression into the site, and blood will be seeping into the proximal compartment. So if that happens and it starts becoming bluish, you should adjust the compression wristband so that it compresses the appropriate side. Most of these resolve spontaneously. Very few would need evacuation. Vessel dissection is a major problem in the upper limb, because when it happens, it usually doesn't happen at the lower level, happens at the axillary subclavian level, and it can cause even retrograde dissection into the aorta. Rarely you need intervention. Frequently you can resolve this by endovascular means, and some reported cases of the need for surgical intervention, especially when it's severely flow limiting and there's a limb ischemia that ensues afterwards. Vessel perforation is not uncommon, especially in calcified vessels. The lucky ones recognize it during the procedure. So you take a shot and there's an obvious, like this one, there's an obvious site of perforation. Usually if you use a long sheath that covers the site of perforation, or a prolonged inflation of a balloon at the side of the perforation would seal that, unless it's a major perforation. It's nothing like the things we face sometimes in the lower limbs when we have a long calcific plaque that ruptures the vessel, and that becomes a major problem. With the upper limbs, it's usually a simpler problem that you can treat interventionally or conservatively and rarely needs surgical intervention. Pseudoaneurysms and arteriovenous fistulae are sort of a combined pathology almost, because in one you're bleeding inside the vein and in one inside the adventitia, and they're easily recognized. They usually present late, months or weeks after the patient had the procedure. In the upper limb, they're not as significant as in the lower limb, where they usually cause swelling, tenderness, and sort of quite a bit of symptomatology. Treatment is usually quite simple. In the small ones, you can treat them conservatively with external compression. With the larger ones or significant hemodynamic ones, they would need some form of intervention, and usually, because of the accessibility of the radial artery, surgical intervention. This is one of the most significant complications and the most limb-threatening complications. And you should be aware of it, because if you're unfortunate enough that it happens to one of your patients that's not recognized, it might be too late by the time it gets recognized. Compartment syndrome. And the compartment syndrome can happen for a multitude of reasons. One of them is bleeding into the compartment. The forearm facial compartments, they can be sort of very specific solid compartments, because they're myofacial and they're quite tense. And if you get bleeding into the compartment that is not recognized early, and there are no signs of external bleeding, they're not massive compartments, so a small amount of blood can cause a compartment syndrome. Then it progresses into the usual symptomatology, which is most significantly neurological symptomatology, because once your patient starts having hand neurological symptoms immediately or few hours after the procedure, including wrist drop or painful extension, then you should suspect that sort of thing. The diagnosis tends to be a bit tricky sometimes, because it's usually a clinical diagnosis, and if you suspect it, you should act. There is a solution for it. Fasciotomy is usually is the usual solution. In some cases, if you're not sure and you don't want to subject the patient to the procedure without making sure what the diagnosis is, you can insert a needle into the facial compartment and measure intracompartmental pressure. However, it's one of these things like a pneumothorax. If you suspect them, act, because the consequences of not acting, which is a fasciotomy, might threaten somebody's arm or life. The occlusion, radial artery occlusion, this is one of the most common complications. It usually happens to about 10% of patients who have radial axis, 8 to 10%. Most of them are asymptomatic and usually not recognized, and there are lots of factors that contribute to radial artery occlusion, including the size, the catheter size, or the not using adequate heparin dose, prolonged spasm as well, or the overcompression with the hemostatic devices. That's why everybody should get an Allen test before you do the procedure to make sure they have a complete hand arch and they have an adequate ulnar artery that supplies their hand in case the radial artery occludes. You can prevent it usually by using the adequate dose of heparin. You can use, if it happens, using the concomitant ipsilateral ulnar compression to increase the flow into the radial artery can also be used, or a patent hemostasis. Patent vessel hemostasis is one other method where you release the compression on the puncture site so that you can allow some blood to flow into the radial artery. Which brings us to a few issues. I thought I'll touch on them quickly because we're talking about access. One of them is using ultrasound for access. Routine use for ultrasound for femoral access is greatly encouraged. Interestingly enough, routine use of ultrasound for radial access increases the rate of occlusion, which is quite a conundrum, mainly because you're trying with more difficult vessels that you're not feeling the pulse with. So there tend to be smaller size vessels that you're puncturing. It's within the comfort zone of the interventionalist. If you're happy with your procedure of the classical feeling pulses going by anatomical landmarks, etc., please go ahead with it. But otherwise, routine use of ultrasound is quite encouraged. Why? Because a lot of vascular complications that are associated with femoral and radial axis can be reduced by your selection of the axis or the right selection for the patient. This slide just shows the different percentages of complications in obese and non-obese patients between radial and femoral axis. Obviously, radial axis has lesser complications, especially in obese patients, and it's encouraged to use. This is another sort of comparison between radial and femoral axis with different indications, and all of them, radial axis tends to have a relative advantage. Ulnar axis is rarely used in coronary angiograms or interventions. If you need it, you can use it. Not much data on its use or the complications that might happen with it, especially if you had a previous radial occlusion. So in conclusion, we can say that these are self-evident conclusions from all that has been mentioned above, but vascular access complications for catheter interventions are a multitude that can be reduced by the appropriate awareness of the different techniques by assessing your patient appropriately beforehand, and by recognizing the complication when it happens early on and getting the adequate assistance and help in dealing with that complication. This is a quote I always use in my talks because it signifies the current status of our science and knowledge. It's a prayer, and it says, from inability to leave well alone, from too much zeal for what's new, from treating patients as cases, and from making the cure of the disease more grievous than its endurance, good Lord, deliver us. Thank you.
Thank you, Dr. Mamoun. Questions, or should I go? Okay.
So Bashar is a consultant vascular interventional surgeon has been doing a great job since he came back from the US in Amman, and he's going to talk to us about DVTs and new advances in the treatment of extensive DVT.
Thank you, Dr. Mamoun, and thank you for staying this late with us today. I'll try to make it as short and interesting as possible. So this is the new frontier. It's a vein case. This is what everybody is trying to get through. How can we get that vein open, and what's the best treatment for DVTs? So I'm going to present this case that I had This is a 47-year-old gentleman. He presented to the emergency room with left leg swelling. He has inability to ambulate and severe pain and heaviness. The ER said that he has huge left lower extremity, and it's probably twice the size, the left as far as the right, and it's tense, and it's kind of bluish, so they thought it might be arterial occlusion, so bad that his left foot is cool. They tried to palpate his posterior tibial dorsalis pedis, they could not. He had the palpable, weakly palpable popliteal artery pulse. Before we go to the next image, they did get a venous Doppler ultrasound. The venous Doppler ultrasound said arterial and venous. The arterial Doppler ultrasound says that there's excellent flow through the common femoral artery, excellent flow through the popliteal artery, and there is dampened blood flow through the posterior tibial and anterior tibial artery, probably monophasic. The venous Doppler, I'm glad that they did, showed that there's extensive DVT, non-occlusive, non-compressible popliteal vein, femoral vein, common femoral vein, signifying extensive DVT, and they recommended doing a CT venogram for further assessment. Given this, now I have a patient with hugely swollen left leg for the last 24 hours. His foot is cool. His whole leg is bluish, and I have extensive DVT with arterial compromise. The idea here, I thought that the best thing to do is to go ahead and take him to the cath lab, do the venogram, find out exactly what we're dealing with, and hopefully we can take care of it in the actual cath lab. So I put the patient prone. His O2 sat was 99%. His heart rate was about 95, probably from the pain and aching. I put some oxygen on him, nasal cannula, and put him prone position, prepped behind his knee. And I will say then that probably at the end of the case why I prepped behind his knee. And I got an ultrasound, and I could see the arterial pulse, and the vein is huge, and it's just full of thrombus. I did ultrasound and guided access into the middle of the popliteal vein. I could see the tip of the needle inside the popliteal vein, and I got a angle stiff glide wire through it. And I took the first picture. This is the sheath. And remember, it's his left leg, but his prone position. So the left looks right, and the right looks like the left. And here you could see that the vein, you can't see a whole lot of contrast through it. Can I make it replay, maybe? Again, this is the sheath in the popliteal vein. And actually, I couldn't see a lot of thrombus in the actual femoral vein. I think it's just distended, and in the venous Doppler ultrasound, because there was no flow through it, so they thought that it was actually DVT. But you could see the contrast. The femoral vein is kind of huge, really huge, distended, and it's kind of cut off afterwards. I put an IVC filter. That way I would not get any sludge or clot inside. And I put the catheter out. The external iliac vein, I could go through it. And you could see here that the common iliac vein is actually completely occlusive. And you could see kind of like a huge clot there. So at this point, I had a couple of things to do. If I had a suction thrombectomy, maybe I could be courageous enough and do like a penumbra or inari or something of that sort. I didn't have it for that patient, so I thought the best and easiest way to do it is do a catheter-directed thrombolysis. So I got a thrombolysis catheter in, and this is a Craig McNamara infusion catheter. It's about 50 centimeter in length, and I gave him actylase, alteplase bolus, and I went back to the ICU for catheter-directed thrombolysis. The next day, it was actually better. 6 hours later, it was actually, his swelling actually got much better. Let's see if this will run. So this is after the thrombolysis. You could see that the clot, most of the clot is better. However, the common iliac vein does not look very well. So it might be that he has a lesion in his iliac vein, might be a May-Thurner that has a recurrent subclinical DVT and caused a fibrosis in that iliac vein. because all the clot is much better except that area into that common iliac vein. There is a flow into the IVC, as you can see there. In that case, I did balloon angioplasty, but the contrast kept actually stuck in there. I decided then to do a venous stenting for that case, and actually got a much better flow after the venous stenting. So this was actually a case of extensive DVT causing phlegmasia, cellular dolens, causing arterial compromise. Treatment in these days goes from catheter-directed thrombolysis to actually thrombectomy. The new frontier is how can we decrease the altiplase or actylase risk of brain hemorrhage and actual hemorrhage, decrease the dose and decrease the ICU stay. A lot of stuff on the market, including penumbra, and I think penumbra is used actually for coronary and for strokes and for venous cases. Inari is one of them. Angiojet is another device. It's all revolves about getting that vein open with decreasing the risk and decreasing the duration of thrombolysis. The swelling, as I said, improved, and extensive DVT, just to keep in mind, it can cause compartment syndrome and it can cause arterial compromise. If the DVT goes into the IVC, now we're stuck in a situation where there's bilateral DVT with, if the IVC is occluded, that we have to do bilateral thrombolysis. I'll be happy to answer any questions or comments. Me or Dr. Mamoun, please. Yeah, I put it, I like to put the filter hook at the renal veins, and that way if a thrombus is catched by the IVC, the renal veins can keep the IVC, the suprarenal IVC open. So, and that way it's also easier for retrieval. I usually retrieve these IVC filters about 6 weeks to 3 months after the procedure. I don't like to keep them in. Doctor?
Is sufficient because venography is by itself thrombogenic in 4%. So it is not advised to use venography in the diagnosis of DVT.
Thank you for the question. I never said that it is advised. I thought that a situation with phlegmasia, cellular dolens, extensive DVT can be treated as opposed to diagnosed. But the venous Doppler ultrasound is more than sufficient for diagnosis DVT. However, just for the sake of argument, the venous Doppler in this situation said that the popliteal vein and the femoral vein is thrombosed. Turns out it's not thrombosed. It's actually, there's no flow into the common femoral, external iliac or common iliac vein. So they were hugely dilated that the sonographer could not compress it. But thank you for the comment. Doctor? Yeah, please.
Below the knee, what do you do for, sorry. Below the knee, do you do any more than conservative treatment? The other questions are, so when you have a thrombophlebitis in the long saphenous, it is up to the junction and protruding into the femoral vein or even the leg. How do you treat? You do the same thing? Like Iliofemoral?
Sure, thank you. Should I answer Dr. Mamoun? Oh, yeah, sure. Okay, so just to be, as opposed to the guidelines, so infragenicular DVT is conservative management with anticoagulation and compression stocking. Infrainguinal DVT is also conservative management with anticoagulation and compression stocking. The iliofemoral region in the DVT, that's where all the studies and all the benefits of thrombolysis and avoiding post-thrombotic syndrome, PTS, arise. So there's no benefit, there's no data, and it's been studied, to do thrombolysis, either thrombolysis catheter-directed or suction thrombectomy, percutaneous, whatever, or open thrombectomy for infrainguinal DVT or infragenicular DVT. As for the questions of thrombophlebitis, so back in the days we used to say thrombophlebitis may be aspirin and non-steroidal. In the last couple of years, if the thrombophlebitis is about 2 centimeters away from the saphenofemoral junction, this is how we treat for DVT. You can ligate that saphenofemoral junction or anticoagulate. There is a risk when it's protruding that it will go to the common femoral. Now anticoagulation is excellent. The second issue, what if it's extensive thrombolysis? So now there's studies if the thrombophlebitis is more than 15 centimeters in length or close to the saphenopopliteal junction or the saphenofemoral junction, treat as DVT with anticoagulation. There's no benefit of doing any catheter-directed thrombolysis for thrombophlebitis.
Bashar?
Thank you for the question.
Bashar?
Dr. Nael. Yes.
Sorry. طيب.
I won't lie.
After putting stent, sorry. After putting stent now, what anticoagulation antiplatelet للمريض هذا?
Thank you for the question. So anticoagulation strategy. So I would like to get Plavix at least or antiplatelets for at least 6 months. For somebody with extensive iliofemoral DVT, there is two scenarios. One of them is non-occlusive iliac vein thrombosis, and another is actually occlusive iliac vein thrombosis. In these two situations, we need, in the occlusive part, it's probably a mechanical issue that caused extensive DVT. The mechanical issue here, after thrombolysis, is unmasked, so we can see the common iliac vein. I would at least do anticoagulation for at least 1 year, at least, for these kind of situations, and then do reassessment. 10% of DVTs is idiopathic, and you cannot know what it is. But for extensive DVT, at least you need 1 year. And I would give them also with the anticoagulation, antiplatelets like Plavix for at least 6 months for the sake of the stent. But at least we unmask the lesion that caused the DVT. Thank you.
Sorry, it was 2 questions become 1.
Sure.
I would like to ask about vascular access. Newly, there's a trend toward the distal radial access and for angiogram and even intervention. Is there any data about its complication and its benefit over radial?
This distal radial is quite an interesting axis and is gaining momentum at the moment, especially snuff box axis. So you're doing the superficial branch of the radial artery, and it seems to have lesser complications than actual radial axis or proximal radial axis. Hydrophilic sheaths, small caliber, seem also to work better with distal axis. There isn't enough data about it at the moment, but it seems to be gaining grounds and is probably encourageable.
حبيبي دكتور أحمد هاي حرشبية هاي يسمونها. So tomorrow I have a keynote lecture about distal radial approach in my center since 2018. I started to do a distal radial approach, firstly for the diagnosis, coronary angiography, and from the 2020 till now, 90% of our work for primary BCI, acute coronary syndrome, chronic coronary syndrome, is through the distal radial approach. The main advantage of distal radial approach, it is a snowbook approach. We have a distal radial, we have a snowbook approach, we have a proximal distal radial, we have 3 modalities, and there is some little difference. The disco trials and disco radial trials, which is non-inferiority trials, reveal that there is no big difference in the major adverse event or complications between the traditional radial and distal radial apart from the hemostasis time. But actually the data will be and the evidence base will be generated later on. It is an innovation. Really, the main big gain in distal radial approach is the less incidence of radial artery occlusion, because you are away from the superficial palmar arch. You know that when you shift from the femoral artery approach to the radial approach, you will see there is a big difference, because there is a less vascular complication and diminish in the rate of the major cardiovascular adverse event and so on, bleeding and so on. But when you shift from the proximal radial approach to distal radial approach, there is no big gain which is clear till now. So, but sure, I will promise you later on, the proximal radial approach is a class 1 indication in the guideline, European or American guidelines. But sure, I will promise you later on, the distal radial approach will be a class 1 indication. Sure that, Dr. Ahmed.
بس تحكي على الديستال راديال ابروش بهمش لفظة. احنا اسمي يونس دعموري من فلسطين. سوينا recently published of the FOREST study, randomized study. The occlusion rate was less in the distal radial approach, and about the pain and the number of attempts was higher, in significant higher in the distal radial approach. The hemostasis time was significant lower in the distal radial approach. The FOREST study we recently published the FOREST study.
So the rate of occlusion, sure, it will be less, but the pain, because and the time, and tomorrow I will present. Yes,
that was my study.
The pain, yes, the pain is due to the superficial nerve. You can avoid it by a local infiltration. Yes.
Thank you. My question to Dr. Bashar. Thank you for excellent presentation. And question, this is case of venous thrombosis, not arterial. Why you recommend Plavix and not the Bigatran or Rivaroxaban?
Thank you, Dr. Natalia. So for, I usually put them on low molecular weight heparin for a week, and then I will switch them to some kind of NOACs, either Rivaroxaban, Apixaban, Dabigatran, the one available on the market. The antiplatelets is because I placed the stent, not because of the DVT. But thank you for that question.
Thank you.
I had 2 comments before finishing this good session. Dr. Mamoun, I faced a good, excellent lecture, but I faced my practice. Femoral compartment lead to compression on the nerve and paralysis of the limb. So this is one of the most serious complications. Dr. Bashar, we had cases of recurrent DVT, and one of them systemic disease, as known as Bashar disease. Did you investigate your patient for such diseases?
Yeah, thank you, Dr. Ali. It's very interesting. So in these kind of situations, in somebody who's young, first multiple DVTs recurrent, usually they present in their 20s. This guy was in the 40s, but I usually do a thrombophilia workup if somebody is in their 20s or 30s. There is 2 things about Bashar disease that looks a little bit different on the venogram. One of them is that instead of finding a fibrosed vein, you will find a semi-aneurysmal vein for some reason or the other, or inflammation. The ESR and CRP for this patient was not high enough. Bahjat does have some DVT. The DVT with Bahjat tends to be around the popliteal femoral area, less a little bit around the iliac vein, but it's something that always crosses our mind with vasculitis and recurrent DVT. Some of the recurrent DVTs, we do send them for a dermatological workup. Some of them we try to find if there is a mechanical element for the recurrent of DVT. CT venogram is very helpful in picking up the mechanical elements. Thank you.
Thank you all. Thank you all. Then, تفضل.
Dr. Bashar, excuse me, I'm gynecologist. What about the postnatal DVT? Usually you use for 6 weeks. antiplatelets or Clexane. I surprised about Plavix. Can you comment on that?
Yeah, sure. So thank you for this comment. Just to make it clear, the antiplatelet, the Plavix, was due to finding a mechanical issue with the iliac vein that had to be stented. So we lack some antiplatelets for the venous stent, but the treatment for the actual DVT is anticoagulation. For the postnatal, at least 6 weeks, we would like to do a follow-up venous Doppler ultrasound and see if there is any remnant for that DVT.
Okay, thank you.
Thank you.
Thank you all.
Thank you all.